and welcome to the latest edition of the GUTSY podcast. Big thanks, as always, to everybody who has been watching and listening on whatever voodoo they watch it on. It's always a pleasure. Can I ask you to subscribe? Because if you subscribe, you'll get the information and you'll get the podcast before anybody else. You'll get the alerts. We're hoping over the next period to release some unique content and exclusive content through that for our subscribers. So if you get the chance, or why not even do it right now, just hit that subscribe button. Follow us on YouTube, or subscribe on YouTube rather, or indeed on Spotify. So a couple of other notes of thanks this week. At the weekend we had a record amount of people supporting us on Kilt Walk. That was absolutely phenomenal, and bearing the bad weather, braving the bad weather, it wasn't the best, but I tell you what, it was really, really inspiring getting down to the finish line. Myself and the lovely Jules, my long-suffering wife, getting down to the finish line on Sunday and cheering a lot of the guys in, and seeing so many charities being represented, some that we know, and it's really quite emotional because there's so much personal stories in there, and it's a beautiful thing to see, and congratulations to the team at Kilt Walk for pulling that together, and I believe it's a record breaker. I've got loads of other things to thank for, but I'll maybe get to them. But the main thing is today, I'm super, super excited to have these guys in. A little bit different on GUTSY podcast. We've got two of the finest gastroenterologists in the country that couldn't make it today. So we've got... So we've got Jonathan MacDonald and Paul Seenan joining us today. Welcome to the GUTSY podcast, guys.
Thank you.
Thanks, Derek.
How are you doing?
Us.
Good.
Yeah, doing well.
Good to get a wee bit of suntan, both of you. Is it Glasgow weather?
Doesn't take much to get me a suntan, to be fair, yeah. Just get outside for about 5 minutes.
He'll have been playing a bit of golf as usual, I suspect.
Definitely playing a bit of golf, absolutely.
Well, I believe there is a bit of a standard there. What are you playing off of just now, JP?
I'm playing off 5 just now, yeah. But,
well, that's not bad.
I like my golf, yeah.
Golfer, Jonathan?
Not really, no, not compared to him, unfortunately. He has to have something he's better at than me, and he's found it in golf, so I just have to suck that one up.
Ah, well, let him play. So everything good?
Yeah, all good.
No, seriously, thanks for coming on. We wanted to kind of mix it up and today and put it out to our wonderful audience, and you know, to ask the experts. There's so many things online and that are quite confusing sometimes, and you know, there's a lot of experts, shall we say, that are you know, maybe with the best intention, you know, throwing some stuff out there, but we wanted to get you guys in, open the forum out to the guys who follow GUTSY, and get a little bit of opinion for you guys and a little bit of ask the experts. So we're looking forward to that. We've had loads of questions in, which has been brilliant, and we will try to get through them all.
Okay.
Try.
Mm-hmm.
Do our best.
We've got time, hopefully.
We'll give it.
You can keep us in line if we're blethering too much.
I think it's us that we'll probably have to keep him in line. He's already blethering too much.
You're probably right, actually.
All right, sorry. It's normally the other way about it. I know this is unusual for you.
Yeah, exactly. I have to sit here and listen to you.
I know. Bless you. Well, the thing is, if I'm talking, you're not talking about football, because I know you've already brought that up at least 6 times since you came in, because something happened at the weekend or something like that.
Indeed.
Indeed.
We're not allowed to talk about football.
So congratulations, Liverpool.
Yeah.
So will we start? Will we just go in it? Will we just go into it? The first question that came in was no surprise whatsoever. Mm-hmm. It's from the lovely Jen Rose. Mm-hmm. Do you know who Jen Rose is? She was actually on the podcast. Mm-hmm. So she wrote wrote and illustrated the fabulous book IBD and Me, which is absolutely fantastic. Now, Jen wants to talk transition.
Yeah.
And she she's got lived experience, so she's been through that with her diagnosis a number of years ago, but also as a parent of a young person, just about to go through transition. And she said, how can young people and their families be best supported through transition and handover process by their paediatric IBD team and the adult team they are joining? Is there a gold standard example of transition handover process that other IBD services could learn from or hope to achieve? How can parents and carers best support their young people through this process too? There's a lot in there.
There is a lot to unpack.
Yeah. I mean, I suppose the first question, or a big part of that question is there a gold standard? I mean, there's guidance on what transition should look like. So from the British Society of Gastroenterology, and there's input there from paediatrics. So there is there's a framework for what transition should look like in terms of, recognising that, that young people are actually at the stage that they should be being considered for transition. So when they're mature enough, to be moving into adult services, but also you want their disease to be ideally well controlled. You don't want it to be in a state of flux. And there's a process. It varies usually from hospital to hospital, but there's usually a process where, there's some engagement with the young person initially, then there's a kind of joint, assessment led by paediatrics and with adults involved, and then it moves on to adults. And I think the most important thing is, having some sort of structure in place, having a good relationship between paediatrics and adult services. It's a difficult time. We've done transition, both myself and Jonathan, with young patients with IBD. I think it's a really difficult time for the patients. I think it's arguably an even more difficult time sometimes for the parents. I think the parents often feel very anxious about it, and we see that. We had tears in the rooms. And I think they often feel that they're going to come to adults and they're going to be suddenly shut out because sometimes the message is that you're not going to be as involved in adults, and that's not something that we're trying to aggressively do. But it's also a recognition that IBD is a lifelong condition. You're going to have to get used to managing it yourself and looking after yourself. And we work a bit differently. We spend more time probably speaking to the patient than we do speaking to the parents and communicating with them. But I think it's transition done properly is a really enjoyable. It's a really good thing to do, and and it's really important because we know the data is there in the background that often we're dealing with very complex IBD in young patients, and often patients within a year or so of going through transition, there's quite high rates if it's not done properly, or even if it is done to the best of your ability, people often disengage with services. So it's really important to get that bit right.
Yeah, it is a tough one for a lot, and I think there's what we hear as a charity and what we've even heard on GUTSY is there's a huge nervousness in it that comes most times from the parent, actually, to be honest with you, and they're to a certain extent. I mean, the best way I can maybe describe it is that the kids being kind of wrapped in cotton wools kind of thing, and there's almost been as if they're getting let loose into the big bad world by going to the adult services, and it's not generally like that in the main, I wouldn't imagine.
I think that's right. I mean, you can have a process in place, and it's good to have good structure and process. And in an ideal situation, that takes place over maybe a year, and you'll have a series of meetings, and there's a sort of staged transition of care. But the real world means that that's not always possible and not always practical, and things change. People can have a flare up. There's a lot of things going on in young people's lives at that point in time. So it's not actually just about transitioning in IBD care. They're going through a huge process of transition in life, from being someone who is a child to someone who is an autonomous adult in all aspects of their life. And so in some ways, what we try and do with IBD transition needs to mirror that process. It's a sequential step towards independence and taking responsibility for the long-term management of their chronic condition. Now, we sometimes see, because of, we're working in Glasgow, there's a lot of people who come to university, so we sometimes see people who've had a partial transition process or have transitioned elsewhere. So sometimes it's about giving people just the tools to make them feel comfortable and confident so that when they get to 18 or 19, if they want to go to university or go and work somewhere else or want to go and travel, that you've given them the tools and the skill set through the transition process that they can cope with and manage the various aspects of their condition that they might need to deal with over future years. And from a parent's point of view, that's sometimes difficult because it is about a little bit about letting go. And that's all the message that I would try and give to parents, is that they need to, part of the transition process is about empowerment for the young person that's going through that process.
Yeah. I think to a certain extent it's a bit of a reflection on life as well, isn't it? Because you know, you quite rightly say, it's that letting go a little bit as well, and you know, that's just natural in any kid growing up. One of the things that I've always found quite interesting, and you know, look at in dealing with the young people that we do as an organisation, and seeing that, and kind of understanding kind of what age certain people are, well, they're just about to step up to the adults potentially, and there's varying degrees of maturity in there. Which, you know, how do you guys deal with that? Because I would imagine that's quite challenging, because you know, you've got potentially a young adult, we'll not call them kids because they're far from that, that's got a reasonable maturity, and then you've got ones that are maybe, you know,
I think that's
they just don't have it.
That's very much factored into the decision, you know, because as I said, you know, the structure is, you know, there's an assessment made usually by the paediatric team primarily about whether or not somebody's ready for transition. You know, are they mature enough? Is their disease well controlled? And those are the type of things, and that's not based solely on age. It's based on an assessment of that young person.
And in an ideal world, we will have a sort of multidisciplinary meeting where the individuals that are coming up to that, you know, age point where transition might be appropriate, those patients are discussed in an MDT setting without the patients and the families being there necessarily, and you have a discussion and we talk about the pros and cons of when you would start that transition process. When's the time point to have what you call T1, which is really where you identify and start to speak to the young person and their family about, we are going to, over the next X period of months, go through this transition process. But there are a whole number of things that you need to factor in, and on some occasions we've gone part of the way through a transition process and then had to stop because it's just been clear that that's not been the right time, something has changed with their health, etc., etc. So you have to have, in an ideal world, to answer Jen's question, a nice, clear and evidence-based pathway, but you have to be able to adapt that and be flexible in your approach as to how you deliver that, because ultimately you have to try and bespoke it and make it individualized and appropriate for the person and their family that's going through the process. Yeah.
And I think there's probably still some work that we could all do to try and make it a bit more individualized, because you'll recognise there's always some patients who come through and it's clear that they need, you know, lots of input at that stage and lots of support, and there's others who come along and they're thinking, really, I'm fine for this, I'm ready, and they almost feel as if it's a little bit you know, overkill for them. So you know, I think it could be a little bit more you know, tailored, and again, I think some of the things that we do, you know, we could transition a little bit better between paediatrics and adults, and you know, very much it's a case of, you know, paediatrics will often deliver care in a certain way, and adults will deliver care in a different way, you know. And there are examples of that. Things like, you know, when young people come to adult services, it's often the first time, if they're getting an endoscopy, that they'll get it done without it being a general anaesthetic, and that can be quite, you know, unnerving for people. Of course, that's the norm for adults, and you know, the vast majority of adults tolerate a procedure like that very well, and you know, and I would say that the vast majority, you know, of the patients that I've had who've come through for transition, even if there's been some anxieties around that, have done absolutely fine with that. And I think there are some patients who could be ready for that at an earlier stage, but you know, those are kind of, you know, differences in the way that we deliver our services that I think kind of contribute to why transition, you know, is quite an important part of, you know, of the care.
Is there anything, just to expand on Jen's question as well, is there anything from either of you guys' perspective for you that's a standout to say that, you know, here's things that we're not doing within transition that would definitely make an impact that you guys would potentially like to put in place?
I mean, I'm not sure the transition model that we've had in the west of Scotland, I think has been a good one. There's been some challenges recently in delivering that as regularly as we'd wanted to. But a lot of those challenges are out with the the scope of the transition setup itself. They're to do with staffing issues and what have you, which are challenges that lots of organisations face, and the NHS clearly does as well.
Just now.
So I think we've got a good service. Could it get better? Well, I think that's everything can improve. You can always iterative improvement, and that's what we would aspire to do. And that comes from looking at what we do. It's really important to get feedback from people. About what their experience is, and there's lots of different ways that you can get feedback. Sometimes we actively go out and seek that, but I think Catherine McEwan Foundation is a great vehicle for patients to feedback some of their experiences as well, and it's important that we've got that interaction with you to that interface to be able to hear that as well. So there's not anything I would say that maybe jumps out immediately at me, but I think we can always improve.
I mean, I think that, the charity does a very good job in offering education and support, and sometimes. Again, as a young person comes through, depending on what age maybe the initial diagnosis was, if someone is diagnosed 13, 14, 15 years of age, they may have some input into their care from the very outset, whereas if you're diagnosed at a much earlier age, you may not necessarily have had enough autonomy to have much input into your care or feel empowered. So again, I think that bit about empowerment on autonomy and taking independence, which, as we've already touched on, it's not just about your health, it's about all aspects of your life. So some kind of additional support for people or vehicle to do that, which is, to be fair, I think where, the likes of the charity that you're on come in and can do a really good job for those people that want to reach out and get that. So it's still it is a nice process, and JP's alluded to the BS, or there are guidelines within the British Society of Gastroenterology about what good transition looks like, and we aim to deliver that, as do most places, but it's not always possible due to service constraints. But it's, even in the best circumstances, it would be nice to have a little bit more time and to give an opportunity for discussion and exploration of a whole issues directly related, but also peripherally related to having a sort of chronic long-term health condition.
Yeah, I think you guys have made some great points, but you've touched on something that I think, like, as an organisation, we absolutely endeavour to improve on and grow, and that is transition, and that support out with what you guys do. So that's absolutely something. And just and Jen's last point before we move on, is there any advice that you would give parents or carers that to help them support their young person through the process?
I mean, I think that probably what I would say is that we're all coming from the same standpoint when we come to transition. We want to support the young person to manage their disease as well as they possibly can, so they can get on with all the other important things in their life.
Of course.
And actually, we'll try and do whatever we can to make that happen. We're not there to cut people out. We're not there to tell people we're going to do things differently and impose things on them. So it's a different structure, but hopefully we're just as approachable and amenable. And if they've got questions or concerns, they should come and they should feel free to voice them, and we'll try and answer them to the best of our abilities. Yeah,
it's like, it's equivalent going to a new school, really. New teachers.
Yeah, it's like going to the high school.
Going to the high school, basically.
And you're worried you're going to get your head shoved down the loo.
It's important.
That was a thing at my school.
Mine too.
It's important that parents are part of the process, and it's to be absolutely expected that they have questions and things that they want to have answers to. But as much as possible, they've got to try and put their son or daughter, whoever, in the driving seat and having the ownership of the process. Because if I reflect on where the transition process has gone well, it's usually 18 or 24 months down the line, you see that person again, and they are asking the questions in the clinic that you hope that they want to answer. They have taken on board personal responsibility for the long-term care of their health.
Yeah.
And I guess the concern I have from being on the adult side of the process is if the transition process is very dominated is not the right word, but if it's very focused on the parents and not on the person who's transitioning, that transition or that transfer of responsibility for long-term care and the building up the young person's confidence in terms of advocating for themselves and asking for questions for themselves can sometimes be lost. So the transition process is nice. It is quite intense. Not intense is not the right word. It's staged, and there is more input through transition than an adult patient will expect to receive going forward. And that's for a variety of reasons, but that's why that advocacy piece is really important, and that once you've gone through the transition process as a young adult, you feel empowered to get in touch with the IBD nurse helpline and explain what your issues or concerns or problems are and do that yourself, whereas in the past your parents had maybe done that. So we're in a situation where in paediatric services, I don't know what the local paediatric IBD population is, it's in the hundreds. When you come into the adult services, we've got thousands of people on advanced therapies, and across Glasgow and the peripheries, you're talking about 10 to 12,000 people in follow-up with inflammatory bowel disease. So from a service point of view, we just can't offer the intensity or the frequency of review and care in adult services as we can in pediatric services. And that's why it's really, really fundamentally important that when people transition into adult services and when someone gets a new diagnosis in adult services, that we do that education piece about the understanding of the chronicity of the condition, the relapsing, remitting condition, the sorts of symptoms and other things that they should be looking out for, and then making contact with us. So we have a service in adults which is very much responsive to when there are flares or crises or other things. But we need to make sure that the patients, the individuals in the adult service, know how to engage, know when to engage, and et cetera, and have the confidence to do so at the right point in time. And transition, I think, is really important for the success of that in the future.
Yeah, it's also, I mean, you use the word that I think is massively important in that, and that's empowerment. Mm-hmm. And I think that as early as possible in that inflammatory bowel disease journey, if an individual was empowered and is taking ownership of the process of the conversation and their condition, then that will help them manage that better moving forward long term. I would imagine. Brilliant. Thanks very much, Jen. Wonderful question. A bit of change in this one. Tonya Love. Hope you're well, Tonya, and I hope Rudy's doing well. And the new arrival. Why are steroids still being used, especially in children, when there is little research showing it successfully helps you reach remission?
So, yeah, it's a good question.
I mean, we're not pediatricians, first of all, so we're not involved in the delivery of care of children. So, I think, fundamentally, the reason is still that if you need a quick improvement in symptoms and someone is in the middle of a flare, that steroids still do have a role to play in some circumstances, because other drugs that we have, which might be much more suitable long-term medications, just don't have the rapidity of response. So there are certain circumstances, and again, I'm reflecting here on the adult patient population rather than the pediatric patient population, where we still do need to use steroids. But I think we are very mindful, and as Tonya has highlighted, steroids don't really produce remission, so they're not long-term treatments, but sometimes they can be a means to an end. But there's good evidence that there is excessive use of steroids in adults, both with ulcerative colitis and with Crohn's disease. And some of that's a bit difficult to disentangle in terms of where the prescriptions are coming from and why the prescriptions are happening. Suffice to say, I think we would all like to reach a point where we don't need to use steroids. And actually, there are some newer drugs now that are potentially creating the opportunity to avoid steroids in some of the circumstances that we've had to use them before. But I don't think we are in an era at the moment where there will be no role for steroids in the future. There are still going to be circumstances in which steroids are beneficial and necessary and helpful. But hopefully those number of circumstances will reduce as time goes by. I don't know what JP thinks about that.
No, I think you're right. I mean, again, I think there is a much bigger focus now on inappropriate use of steroids. And I think there's a recognition that, for too long, we've been using steroids for 70 years in IBD, and I think I would agree with Jonathan that they do have a role, but we need to recognise that overuse of steroids is an issue, and it has been an issue for a long time. Where I see steroids still having a role is in things like admission avoidance, preventing people coming into hospital when they've got severe symptoms, and sometimes they will have a role in that, in buying you some time to get them onto a more effective treatment that is going to get you into remission. And there's evidence that they have a role in severe acute colitis and preventing patients needing surgery as a consequence of that. So while they aren't they're clearly not a long-term solution for people, I think they will still have a role. But the days of us giving people multiple courses of steroids before they subsequently earned their next step up the therapeutic ladder, I think is hopefully changing, and hopefully that's in the past. And we've got good data recently that supports early treatment, early effective treatment in our patients is better for them. They'll do better. And so, patients shouldn't really be having multiple courses of steroids before they get on to something else. But yeah, I think they will still have a role. There are other alternatives. The question was about paediatrics, and again, we're not paediatricians.
Of course.
But one of the things that we, I think, have learned from paediatrics is, how useful nutritional therapy can be in our Crohn's disease patients. What I often say to my adult patients is, the standard approach in a new diagnosis, for example, or a patient who's flaring with Crohn's disease in paediatrics, is not to give them steroids. It's often to give them exclusive enteral nutrition, and that's something that we are doing more and more in adults. It's historically been something that we didn't think worked in adults, but also we didn't think adults would comply with. But I think attitudes to diet have changed, and people are keen often to avoid steroids because they can have a number of side effects. So we're seeing an increase in the use of nutritional therapy. We've been involved in the Catherine McEwan Foundation supported studies looking at that have involved our adult population as well, and I think there's more work to be done in that regard. So I think we are trying to move away from steroids. I don't think you're going to get to a stage where steroids aren't used at all, but I think we should be aiming to limit the steroids that we do use.
Yeah,
and I would back that up. And JP made the point which I was going to make, which is I think that we're closer, that the role for steroids in Crohn's disease is reducing more quickly than it is in ulcerative colitis, partly because of the opportunities for nutritional therapy. There are drugs that are coming through. Medications all have potential for side effects, okay, but everyone's very, very aware of the potential issues with steroids. But there are drugs that are coming through that will potentially, in select cases, particularly with ulcerative colitis, give us the opportunity to either avoid altogether or to reduce the exposure to steroids. So we're not there. It's a journey that we're on. We would like to be in a position where we never had to use steroids. I don't think that will ever happen, because sometimes the disease is very unpredictable, and sometimes at diagnosis, if someone's got acute severe colitis in particular and end up in hospital, or as JP said, you're trying to avoid hospital, then sometimes a short, sharp course of steroids is helpful. But it is in that context, it's a means to an end to get you on to longer term appropriate treatment, which avoids steroids altogether, ideally.
And one of the points that you made, which is, so there's evidence from, probably about 10 years ago in the UK looking at, steroid use, and there was still an excess in steroid use, and there was concerns that some of the steroid use that was identified was maybe inappropriate. And Jonathan made the point that sometimes it's difficult to track where that steroid prescriptions originated. One of the things that came out of that, and I think that we still sometimes see, is that steroids are prescribed in primary care. Now, our GP colleagues, are a great source of support for our IBD patients, and they're incredibly busy, and some of them are very used to managing IBD in the community. But I would say if one of my patients goes on to steroids, I want to know about it. And I think sometimes what will happen is you'll get a patient and they've maybe had a couple of short courses of steroids, and we've not known about that. And the reason I want to know about it is not because it was the wrong decision at the time, but it will potentially influence how I'm going to manage that patient, because I don't want them to be getting 2 or 3 courses of steroids. So it's going to have a bearing on whether or not I'm thinking, do we need to escalate this treatment? Is their background medication effective enough? So a message I would say, and I don't know if you agree, but would be if you are getting steroids out with your hospital setting, not to say that that's the wrong thing, but I think your team would want to know that. So, if one of my patients was getting steroids, I'd want them to let the helpline know so that we can take that into consideration for their treatment.
I think it goes back a bit further. It goes back to what we were actually discussing before, which is there is an element about education from a patient point of view, because lots of patients are aware that steroids are bad for them, but actually there's a significant number of patients who aren't always aware of the risks of steroids in the long term and don't necessarily appreciate those things. And the benefits of steroids are actually, they go a bit above and beyond just improving your gut symptoms. They can give you a feeling of higher energy levels. They can make you feel a bit elated or happier, at least in the short term. They can improve your appetite. So actually, if people are not fully educated about the risks of steroids as well as the benefits of steroids, we sometimes see people who've maybe been diagnosed, I don't know, a long time ago when we didn't have the luxury of other drugs, that have become very used to steroids and actually really find it very difficult to countenance coming off steroids altogether or not having steroids. So there's a lot of ingrained behavior for people who've had, particularly for people who've had the condition for a long time, because steroids steroids make people feel better when they feel as if they're in a crisis, and not all of that's driven through the gut inflammation, and some of the other medicines that we have don't have those, so they don't have those effects. So sometimes we have to spend some time explaining to patients, yes, that those steroids are making you feel better in the short term, but actually in the longer term, there is far more risk than benefit from recurrent steroid use, and we need to look at a different strategy. We need to look at a different way of managing your condition long term. Yeah,
we Seb Tucknott on the podcast a few weeks ago, who's from IBD Relief. I don't know if you've ever met Seb.
No.
It's a wonderful project he's on. Lives a UC, but living very well, and he spoke about many years ago now when he was all, to be honest, he was almost self-medicating, because the steroids got him on a level, and he felt as if he was living a normal life, and he was kind of like, well.
And part of that's not,
future,
part of that's, as you're describing, is maybe not knowing the downsides of the steroids, but it's also not necessarily having an awareness that there are alternatives, and and it may be that those alternatives haven't been explored. Again, the message that I would have is if you're getting steroids, and we use steroids in medicine in lots of different areas, so people are comfortable using steroids, but if you're getting steroids and you're concerned that that might not be the right thing, or if you've got any concerns about your IBD, it's about speaking to your local team, and that'll get factored in.
Yeah, of course. Some fabulous conversation in that. I hope that answers a lot of what you're asking there, Tonya, and thanks a lot for it. Joanna Rowley. This is probably not for you guys, although you can answer it. No, you'll have an opinion. You'll have an opinion.
Undoubtedly.
It's not medical. That's why it's not medical.
We've got all sorts of opinions.
I know where does the talent end? Can I ask you a question?
It depends what the question is.
Yeah, of course you can.
Right. So how long have you been in inflammatory bowel disease?
So I've been doing gastroenterology for 22 years, probably. I think So
you started when you were about 40.
Yeah.
Always.
I'll gloss over that one. So and you kind of, the way that your training goes is that you do medicine and then you identify gastroenterology, and then
he's not been an IBD specialist for 22 years. He's been training for about 22 years.
Then you focus on what you're going to do.
So you didn't. I mean, I know that on day one you thought you were an expert, but no, I'm not. You're maybe forgetting now. There was a bit. It took you at least 2 or 3 days, I think, before you got it all sorted out. It wasn't day one, JP. Come on.
No, but I mean, the question is, how long have you been in IBD? So your first IBD clinic I did was probably 22 years ago, and you develop you specialise over time. And did you know then that you were wanting to do A, gastroenterology, B, IBD? Yeah. Probably not. I have to say, when I think back to the first clinics I did in IBD and the way that we practiced back then, and even just reflecting on the questions that we've had, our practice is astronomically different. We had lots of patients who were getting lots of steroids, and we had very limited treatment options that we could give beyond that, which was one of the reasons why we used that as a crutch, because we were much more restricted in the options that we could offer our patients, and it's changed enormously. But not just that, the way that our service is delivered has changed. It used to be you saw your consultant and that was kind of it. Now it is a much more of a multidisciplinary team game. You've got your IBD nurses, which are an essential part of the delivering care. Yeah. We've got dietitians, we've got pharmacists, we've got our, we've now got surgeons who, it used to be that colorectal surgeons, and it's still the case in some areas, that you've got colorectal surgeons who'll do a bit of inflammatory bowel disease and a bit of this and a bit of that. In our hospital and in other areas now, you're having surgeons who are focusing more on inflammatory bowel disease specifically. So I think the whole landscape of the care that we deliver has changed.
Is that your next step? You're going to be an IBD surgeon as well? Is that where
No, definitely not.
Oh, he could
definitely not.
He could probably do that.
Too fiddly for me.
It's probably take him to Sunday to learn that.
Well, maybe. Depends if he's playing golf on Saturday.
Right, maybe Monday.
I feel as if I'm getting picked on here. This is bullying.
He started it.
Yes. Have you read the bullying and harassment policy recently?
The Derek McEwan Foundation bullying and harassment policy.
Yeah.
Your wife's phoning you.
My wife is phoning me.
Your wife's phoning you.
Yeah. Should we answer that?
She's phoning you to say stop.
Question.
Should we answer that? Right, we'll answer it. Hi, Julie.
Hello.
Right, Julie, we're actually recording the podcast right now with Jonathan and JP, so you're actually going to be in the show, and I left my phone out so that I could look at Instagram, but the guys have seen that you're on the phone, so would you like to say hello?
Hello.
Hi.
Hiya. That was good timing, because they were picking on me there.
Do you want to join in?
Saved by the Bell.
He actually literally was saved by the bell because he was getting some magnificent stick from his partner in crime here. So
I do apologise.
No,
don't apologise.
Definitely don't. But I'm going to go because we are right in this.
Okay. And do you know my silly question was, could I borrow one of your gazebos?
How many gazebos have you got?
We've got several gazebos for events.
Oh my God. Right, okay. I didn't realise you would have been started yet. Sorry.
Yeah, you're going to be in the show. Who would have thought, Jules?
Are you going to give her an answer?
Yes. Sorry. The answer's yes, and I'll even bring the gazebo with me when I come down to see you.
That's what I was checking, but it's only Wednesday. I didn't really need to know the now, but I've just offloaded it.
Right, okay.
Right, bye now.
Bye now.
Bye.
Cheerio. Okay. So another question ticked off the list.
Ticked off the list. Well, what's your answer to say, and your opportunity to slate him? How long have you been in IBD?
So, I became a consultant now, about 12 years ago. And during that time, my focus on IBD has evolved and grown. But like JP said, I've been on a journey where gastroenterology was the sort of first choice that I made in terms of professional choice to train in gastroenterology. And then as I went through the sort of 5-year process of training, so you do 5 years of specialty registrar training. And during that process, I became more interested and focused on IBD. And I guess most people who weren't in the medical profession might perceive that we are IBD experts. I don't know, but we don't do exclusively IBD in our consultant jobs. We have lots of other roles. And actually that's one way in which the healthcare system in the UK maybe differs from elsewhere. So if you've got IBD and you're in France or Germany, probably the consultant that you look after, that looks after you or that you see, probably does IBD and very little else. Not always the case, but that's often true. Yeah. Whereas in the UK, there are various levels of time that consultants spend in their jobs focused on IBD. But even myself and JP, who do quite a lot of IBD stuff, we have several other commitments within our NHS.
Well, I think that's changed as well over time. Yeah. I mean, it used to be that a gastroenterologist did a bit of everything. You did liver disease, you did inflammatory bowel disease, you did your endoscopy. And again, we often still do have quite a varied practice, but it's become less common that everybody does everything, even in, smaller units, more peripheral hospitals, outside the big cities. And that's one of the reasons is that, things have got more complicated.
Much more,
the amount that you need to know everything. You're probably never going to know everything about any topic, but
I know you're definitely not going to know everything. He thinks he's probably maybe not going to know everything.
But the amount of stuff that you need to know for IBD and liver disease has expanded dramatically, and so people have become much more subspecialised. I think that's a good thing.
Yeah, it's absolutely true. It's become more complex, but in a good way, because I don't want that the impression that creates shouldn't be that it's bewildering or unmanageable.
Yeah, of course.
Complex. It's become more complex in an evolutionary sense as. Actually, the more proactive you are in terms of managing the condition long term, the more engaged in the process you are, the more complex it becomes. So before, if you go back a generation or two, as JP's kind of hinted to already, you would have to earn your step up on the ladder in the medication. So you would be waiting until someone falls on the floor and then trying to pick them up and start a new medication. Whereas now we have a very different philosophy, and that philosophy brings with it complexity in terms of how you monitor and how you assess response to treatment. There are more treatments, there are combinations of treatments, there's dietary therapies, so there's all sorts of things that make IBD care much more complex. But that's not unique to inflammatory bowel disease. That's the state of the world, and that's the way that the management of many chronic long-term health conditions is going. It is becoming much more complicated. It's very, very difficult. It's impossible for us to keep on top of all of the research and evidence that's coming through, even in just inflammatory bowel disease. And so it's naturally, there has been an evolution in terms of subspecialization towards inflammatory bowel disease in our profession, gastroenterology. Also, people specialising more in endoscopy, people specialising more in liver disease. There are challenges for that in terms of access to care through the NHS when people become more subspecialised and services, etc. But that's makes it more interesting, but it's also part and parcel of the way in which healthcare is delivered now and is changing over time.
Yeah, it's changing
massively.
Yeah,
absolutely.
Say nice. Joanna Rowley, help funding part-time apprenticeships and employment when not stable. I think I know what you're getting at, Joanna. I think from a charity perspective, that's maybe something that's maybe more for our side of things. We absolutely recognise that the employment challenges and even educational challenges as well within our community, and that's why we have the Catherine McEwan Foundation Scholarship to support our young adults and younger kids as we develop the service to help them achieve academic success. Something that is most definitely around been spoken about around the table is how we can expand that and support employment in some way, shape or form. And to be honest with you, it's not something that has gone far, but it's absolutely in the conversation.
The other side to that as well is, if you've got... So I alluded to it earlier on, our job's to try and, ideally keep the disease well enough controlled that people can get on with the rest of their lives and all the other things that are important to them. Because actually, what really matters to them is not, how their IBD is. It's all the other things they want to do. Usually,
life.
Yeah, exactly. And if people are struggling, it's very common that people are coming to us and they're looking for, can you do me a letter? Just giving a bit of background to support, the fact I missed my exams, or I've been struggling with my coursework at university because my disease has been active, and that's something that we're always very happy to do, because IBD is something that we know a lot about and you know a lot about, and the people who are asking these questions are having lived experience of it, but there's a lot of people out there who don't, and they don't. They look at somebody who's young and fit to their eyes and they think, why could they be having a problem? I'm certainly more than happy. It's often quite a generic letter just explaining, this is a chronic disease, and it flares up and it's going to have, it's potentially going to have an impact and it should be taken into consideration. But we can always provide more detailed information, on request, and and we can provide a bit of that support. Can't necessarily provide the financial support side of things. That's probably more something that needs looked at from a third party perspective. But we can certainly give our backing.
I think those points are all absolutely valid. Again, when somebody is seeking my help with a situation like that, I'm always, as JP has said, happy to offer whatever support I can. But it also triggers for me a conversation. Well, why? What do we need to do to make the situation better? We can't yet, unfortunately, make everybody with IBD well all of the time. But the aspiration that we should have, and what I always say to patients when I'm meeting them the first time, or they've got a new diagnosis, is what we should be aspiring to is getting to a point where if you require medication for your condition, you remember to take it at the appropriate time points, and then you forget you've got the condition and you just get on with your life. So the norm for someone with IBD doesn't need to be lots of time off work for hopefully the majority of people.
Yeah.
We absolutely need to offer support, and the condition, unfortunately for some people, can be very complicated and very difficult to manage, and we need to offer support, but we must always go back to see what can we do better to get your baseline health at a point where if you want to travel, you can travel. If you want to do a certain job, you can do a certain job.
Yeah, I think that's a really important message, because again, the Gastroenterology McEwan Foundation's got, it's got a long history of, engagement with paediatrics, and we started with a question about transition, and some of the people who are listening to this podcast, hopefully somebody will listen to this podcast,
I've no doubt it's going to be the most popular,
but they might be younger people, they might be young adults who haven't got to the point that they're at university or going into a job or doing an apprenticeship. And again, I think it's an important message that I would say there are always exceptions, but the vast majority of my patients can go in and do all the things that they want to do with their IBD, and and if they can't, then as Jonathan says, it's our challenge to try and hopefully manage that to a level that they can.
But I mean, again, the Catherine McEwan Foundation has come up and has done fantastic work in paediatric IBD and transition. So we see again across the board challenges. So there's a peak in later life of people getting diagnosed with inflammatory bowel disease. So we've actually got quite a lot of patients in their 70s and 80s with inflammatory bowel disease. And, I can think of, and you all know people, and they come and they just say, we've talked about golf already. But, if you are retired and then you get in later life affected by this condition, and you have an accident, you have fecal incontinence, you soiled yourself, it's so impactful. And
absolutely.
So at all points in journey after your diagnosis, if the condition isn't well controlled, it can have significant impacts on your life. If you're of working age, it might be your ability to work, but when you're retired, it might be, and you're older, it might be you can't get out and do the shopping, you don't have confidence to take your dog out for a walk, you can't do golf anymore. So again, that's a little bit about the relationship between you as an IBD nurse or an IBD doctor, understanding what's important to the person that's sitting in front of you. What is it that they need from me in order to make them feel confident and able to do all of the things that they want to do. And unless you have that conversation and actually understand what it is that's important to them and what the priorities are in their period of life, that they're in at the moment, then you will sometimes miss the target and you won't align the things that you need to.
I think that's a great point. You know, what is important. I mean, I think that's again where we come into a certain extent. You guys are doing what you guys do from the clinical side of things, you know, from that, and it's you know, how can we help you in your life to you know, to, it's no cliche, isn't it, to live your best life, but being serious, it's like how can you do it? How can you live life every day to the best of your best humanly possible, so that you can enjoy it, you know, because I mean, essentially that's what you're there for. But sometimes you need a hand.
But, you know, and I think sometimes some people that come to clinic think, I mean, maybe we look very harassed when we're in clinic. I don't know. People sometimes feel that that's not the sorts of conversations that they maybe ought to be having when it's all, you know, the conversations that I have in clinic aren't all about blood results, medicines, scans, tests. You need to have that. Do you know I feel very strongly about that. You need to have that conversation. And people know, and again, it goes back to the advocacy. People need to know that these things are important, and therefore they need to raise them, or we as person on the other side of the table needs to create an environment that means that they feel comfortable and able to raise these things, because they're all linked, and that's what you were saying. So you need to focus on all aspects.
See, hearing you say that makes me happy, because it's that the whole holistic approach to looking at the person and not just the condition. And so often we hear, "Oh, I go in from a clinic and it's." And it's all condition related.
You know, it can be, you know, closing the name. It can be very clinical. You know, it can be very, how many times you go to the toilet.
Yeah, of course.
I have to say, you know, I'd like to think like Jonathan, that, you know, ask a bit more around, and I think there are important issues that people, you know, should feel free to raise with us, but we should also, you know, be, you know, a bit more proactive about, you know, raising with them things about, you know, family planning, sexual health, you know, mental health, all these different things, you know, are aspects that we should be, and you know, bringing into the conversation. It's difficult because there's time constraints there. But, you know, you know, if we don't get to the point, then people should feel free to bring it up with us, because we're not just interested in how many times they're going to the toilet and whether they're passing blood.
And that's why it's, I mean, IBD care is a team game now. Whether it's, you know, we have pharmacists in our team, we have IBD nurses, we would like to have more formal psychology support. We have trainees coming through our clinics, and they offer, you know, really important input to our service. So we can't always answer all the questions. In fact, normally we can't deal with everything all within one clinical appointment, but at least getting out on the table and an understanding about what the important things are, and moving forward, setting a priority list of things that need to be addressed.
But I also think that you're absolutely on the money when you say it's a team game, but part of the team is the actual person living in the condition as well. And I think that's
the most important person.
Not everybody gets that, and you know, there's not all the time, but you know, there's a degree of those guys are looking for you to have a magic wand. Right, well, I'm here, and you're the expert. You need to fix it. But you probably need to fix it now. And that's not for everybody, but sometimes that is it. And you know, it's got to be a two-way street, isn't it? It's got to be like, okay, we can take this far enough, but you know, you need to be empowered and have a degree of self-management that you can work best for you, because they are the, you know, the playmaker in the team.
Indeed.
I think the whole idea of self-management has come on an awful lot. I mean, we've got quite a lot of patients, you know, going back to, you know, when I started doing IBD clinics, you know, patients with very stable colitis, they would just come up to the clinic, you know, every 6 months they would get seen, regardless if they've not flared in 10, 15 years, you know. And, you know, if you've got a job and, you know, a young family and you've got places to be, that's not a terribly good use of your time. And, you know, there are different models. We encourage patients to self-manage. You know, our helpline's really helpful as giving that safety net for people, you know, if they do run into problems. But it's an unpredictable condition, but in order for people to be able to self-manage, we need to get the, you know, the education bit right, and we need to have we need to be able to provide that, you know, the structure that allows them to get back into the service, you know, easily, if they need us, because you can self-manage and you can be absolutely fine for 5 or 6 years, but the reality with inflammatory bowel disease is it can flare unpredictably, no obvious trigger, and then you need to see us quickly when you hadn't needed to see us at all in 6 years, and that's difficult to factor into, and that wouldn't have been made any better by bringing you up to clinic every 6 months when you were well.
Yeah, totally, because it's something that we are always trying to push is that that your condition doesn't define you. It's part of you. It's not going away. Hopefully, it feels as if it's going it's away a lot of the time, but you shouldn't be defined by it in any way, shape or form, and try to get that that kind of positive outlook. Sharon Brady, thank you for putting in your question. Let me just get this right. There's a lot of scientific evidence now that gut health is linked with medical and mental health.
Yeah.
Would you find it beneficial that stool testing went further than just your regular calprotectin? Lots of our young people suffer mental health conditions associated with IBD and deficiencies in vitamins and minerals, as they can't absorb it through the usual absorption process. I'd love to see a more holistic view overall of the young person or individual. I think you kind of touched on that a little bit by looking at that holistic approach.
There was a bit in there about stool testing and about calprotectin. We use calprotectin a lot. I'm sure the audience here would hopefully know that calprotectin's it's an indirect measure usually of the inflammation in the gut. And I think there was a question there about other types of stool testing. I think there's a lot of stool testing out there that people can go and they can get done. They can pay to get done themselves, looking at their microbiome and such like that. And that is undoubtedly an important area, but it's a very difficult area to tease out. And and often it's not something that those results give us a particularly good steer as to how we're going to influence that. So I think the latter point of the question, which was more about trying to take a holistic approach, is the really important thing. And when it comes to what we've been talking about already about different treatments, and a different approach to our service, looking at mental health, involving our dietitians and focusing on diet, talking about other issues that are important to the patients, like employment, issues they're having with money, sexual health, family planning. So, and I think that's that's where we come to that holistic view. I think
that just kind of with our experience at our end of the spectrum is that a lot of the things it's how we're living life. Like where the condition is, like you saying, having to look at that holistically, and I think it's really important, because a lot of the pressures that they're under, whether it's just thinking an example recently, someone's moving house, and maybe some relationship issues or whatever, and that stress, they become inflamed and everything that goes along with that. But I think that comes down to a lot of self-management, how you manage that as well.
So, the self-management tools that we have, so we obviously have a framework in terms of treatment changes that people can make as part of self-management. And they're largely symptom-guided, which is important to be able to do that with symptom guidance. But actually, we know that symptoms and what's happening at the level of the gut in terms of inflammation don't always marry up very well. Fecal calprotectin we use, but it's the best that we've got, but we recognise that it's not very good. And what it doesn't do, if you consider someone who's got diabetes, for example, and they might now have, a lot of people have got insulin monitors that monitoring their blood sugar minute to minute and making adjustments in their insulin treatment on the basis of the blood sugar before the blood sugars ever really become abnormal. And that's massive strides forward in terms of what the situation was 15, 20, 25 years ago. Now we're way behind that in IBD, but what ideally you need is something that gives you that. If you get a calprotectin 3 times a year, which is pretty good, if you get someone to hand in a fecal calprotectin 3 times a year, it gives you a snapshot on that particular day, but it doesn't tell you anything about what's happening in between times. So to get to that point where you've got really holistic care, but also really time-sensitive care that we can change to the adaptations that might be needed in your treatment on a day-to-day or week-to-week basis because of stress and things. First of all, we need to make get some evidence that changing your treatment in that way is effective and beneficial. But then secondly, we need to have a way of actually what is happening in your gut on a day-to-day basis. And that's one of the challenges with inflammatory bowel disease. There are other conditions that have similar pathophysiology in terms of psoriasis and inflammatory joint conditions, but it's a much easier to examine a joint in a clinic, or look at a joint, or take an x-ray, or look at someone's skin and see how effective a drug has been in terms of clearing up psoriasis or eczema. Whereas we've got much more rudimentary and difficult to use tools that tell us on a day-to-day or week-to-week basis what's happening in the gut. So we have to extrapolate to some extent. So we do absolutely need, but it's not an easy journey, but we absolutely need better ways of knowing and understanding the interactions that's happening in the inflammatory process that's happening, and how dynamic that is on a day-to-day and week-to-week basis. Yeah. And I think we will get there, but not soon, probably not in my professional lifetime. He's quite a bit younger and smarter and
really?
Yeah, than me.
So that was a younger, but not as smart.
I had a hard paper round, but yeah, I'm quite a bit younger.
Well, you think you know people. Jude Curry, thank you for your question, the lovely Jude. I like this one actually. Would they consider having middle wards for transition 18 to 25-year-olds? I know where this is coming from, because Jude's son Joe is going to kind of go through that.
It is a really good question, and going back a few years, we were having quite detailed discussions with the paediatric team locally about whether that is something that we could deliver. I think even back at that time, which was probably 2017, 2018, we were having those discussions. Probably. There were going to be significant challenges in delivering that and doing that. But they were challenges that we were prepared to take on. And then, of course, there were a number of things that happened, other pressures on the services in both pediatrics and adults. And then COVID came along, and we just haven't quite re-energized that conversation afterwards. But there are, I mean, you're talking about, I think there's only 1 or 2 services in the UK that offer that.
So was the question about a middle ward? Was that what the phrase was?
Yeah, pretty much.
So it sounds like it's more focused maybe on the inpatient
all right,
side
sorry,
of things.
I picked that up wrongly.
But what you're getting at is, and we did have some discussions about having a kind of, young adult,
I think both are relevant.
Young adult service, because there are specific issues that are relevant to young adults that maybe are less relevant to someone, in their 50s or 60s or 70s or 80s. Maybe not, but that, and there are examples of services like that in the UK. There's one in particular in London that I'm aware of. Yeah. I think having separate wards for patients of that age, again, is potentially something that I would find more difficult to see coming into practice. I think certainly where I work, the wards have a cross section of patient ages and different conditions sometimes, but if you had a good service that recognised the specific issues that young adults face, and they were able to input into the inpatient service, I think it could deal with a lot of the issues that are maybe at the root of that question. So
I don't know whether I'd misunderstood part of the question, but I don't know where we work. Our inpatient care is in the Queen Elizabeth, and every room in the hospital is single bed. So there are certainly challenges on wards about the environment. So I don't know whether Jude means it's about the environment of the ward and having, or whether it's the specific care that you get. But I think hospital environment and ward environments are changing for the better globally. And I agree with JP. I think there would be some challenges in having. I mean, fortunately, a lot of the time you won't. IBD now is a condition where, by and large, we should be significantly reducing the amount of time that people need to go into hospital. Okay, and this is a conversation that we are, having and explaining internally. That if we deliver an optimal IBD outpatient service, it significantly reduces the number of people who end up in hospital. Now, by in no means all circumstances, but in some circumstances, when people are admitted to hospital with a problem related to their IBD, you can trace back points in time in the days, weeks or months before that where there has potentially been a missed opportunity for an intervention which would have made a difference. So I think from an organizational level, and again, hospitals care for the diaspora, everybody and everything, okay? And we tend to come at things, understandably, as patients and as IBD advocates and IBD doctors as we are, we have a very IBD focused hat on. But hospitals, we need to be slightly pragmatic and slightly mindful of all of the other pressures that are on the hospital. I don't know what the numbers are, but I'd be surprised if there was enough 18 to 25-year-olds at all in what's the biggest hospital in Scotland to actually merit a ward of patients.
Yeah, I think one of the challenges, and we've heard that a few times, and I think that's what Jude's kind of getting at. I've heard that in males and in young girls as well, is that they're maybe 18, 19 and getting into a ward and of wide and varied spectrum of demographic and challenges and stuff like that, and it's, I think the best word that I can think of just now, it's quite inappropriate.
Yes.
And that has led to some quite distinct challenges for them.
I would completely agree with that, but I would say that is almost always the same for every patient in that ward environment, and that's the environment that's the issue, rather. And so, and again, as I said, where we work, and we're fortunate in many regards, doesn't suit everybody, but having individual rooms and individual patient care for a whole variety of reasons is the way that things are moving forward. A lot of hospitals don't deliver that yet.
It's an interesting thing, but as well that I mean, we can probably digress in that kind of the individual private room to the ward, because before, in my experience, like getting that room to yourself or a family member in it was brilliant, and you know, and the benefits of it, and that was the thing. But now that people have that, you're hearing others, it's isolating, there's nobody to talk to.
I think both have always been true. Some people like their their independence and their privacy, and particularly for older patients, being who maybe don't get a lot of visitors, being in a room on their own can be very lonely and isolating. So I think there are pros and cons, like in every situation. I think the point that Jonathan makes, I think it's unlikely that kind of model that's described as an inpatient setting is something that's likely to come, if I'm being honest. But I think the point that you made earlier on, which is, what we should be trying to do, and what we are, is admission avoidance. It's trying to prevent people coming into hospital in the first place. And I think the more treatments that we've got available, and the appropriate use of those treatments, the getting your surgical services set up correctly so that patients are having planned elective surgery rather than emergency surgery, should hopefully minimise the amount of time. It's never going to take it away completely, but that's what you're aspiring to.
I mean, I would agree with all of that. I think if I was to look at what would be deliverable and what would be impactful, perhaps. So again, there are some models of care. One of the things with people with inflammatory bowel disease, when they are in the unfortunate position of being poorly and ending up in hospital, is you might go into hospital one day and end up in under a team of surgeons, and you might go into hospital on another day with the same set of problems and end up with a team of medical doctors or gastroenterologists. And there have been some places where they've tried to integrate care and have a ward which has both consultant gastroenterologists and surgeons with an interest in inflammatory bowel disease inputting to patient care and having a shared care model. And I think there are some attractions in doing that. But again, that has to be scalable and deliverable, and potentially it would work in somewhere like the QE, which is quite a big hospital, but wouldn't work so well in a smaller district general hospital because of lack of expertise and lack of patient volume. But I think the underlying thing, as JP has said, is increasingly someone coming into hospital with inflammatory bowel disease is, well, it's something that we want to avoid that unless it's an elective and agreed admission for surgery. So what we need to be doing, I think, the long-term strategy is to improve our outpatient services, so that we don't miss any opportunities to make somebody better before it gets to the point that they need to come into hospital.
And I think you've touched on something that's very relevant. obviously I'm in no way an expert in this, but you hear stories every single day in life and have done for a long time. But that, when you say when the individual gets into that hospital setting, they're in an inpatient, if you look back at the history of it, there's points in there that there could have been an intervention to stop that. And I think of a few examples in my head where, definitely the case. Yeah. Definitely. So that's really relevant. Well, thanks for that. Thanks, Jude. Always good to hear from your good self. Moving on, we've still got loads to go through. Rhoda Campbell, who's said, this is fantastic. Hopefully she feels the same after the end of it.
Wait, sorry, Rhoda. Proofs in eating. Yeah.
Rhoda, please send us in. Please send us your review.
As long as it's a good one.
Give us a rating on YouTube if it's good. If not, just do it privately. Can't have the 5-star reviews getting battered.
Absolutely.
So she has a long question, so bear with me. I was on the list and accepted for small bowel transplant down in Oxford. Because I have short bowel syndrome and on PN fluids for magnesium and potassium malabsorption. Okay, thank you guys. But just had a letter to say they are finding their findings without seeing me. I'm not sure what she means there. And going on past scans that they want to join up my small bowel and colon. So I'm trying to understand how that will help, but also I really don't think I could cope mentally and connect it up again. I've had for 28 years running to the loo 20-30 times a day, and my stool is now sadly like water. That doesn't sound a fantastic experience.
So it sounds like Rhoda's got, in a difficult situation. She's got a short bowel, which is something that we thankfully don't see an awful lot of, but it can be a really difficult thing to manage. Very specialised thing, and it's it's obviously something that she's been referred somewhere else for. So it's really difficult for us to comment on something like that. When we don't know the history and we don't know the background and we don't have all the information.
Of course.
And neither of us, I would say, are experts on that side of things, which is what is generally termed intestinal failure, where your gut's not working the way that it needs to be.
But I think fundamentally what is described there's the medical side to that, but there's the communication side and there's the aligning of genders, and it goes back to what I said about what's important to me, what can I cope with, what is something I could contemplate or see, or if what Rhoda is being suggested as a treatment is completely different from her expectations up to this point, then that conversation, I think, needs to happen so that Rhoda understands why the different recommendations are now being made. So that that is always really important, because if you do, again, going back to advocacy, these things all need to be addressed beforehand, because if someone is going to go through major surgery, you need to have these questions answered before, so that you know what the expectations are on the outside, on the other side, and then there's no misunderstanding or long-term regret or whatever because those conversations didn't take place. So I think that does sound like a very difficult and a very challenging situation, and I'm sorry to hear about that, but it sounds as if, on the positive side of things, been referred to the UK Centre of Excellence and for some input there. But I think that there's a piece of work to be done about communication, discussion about what. So
I think the feedback for Rhoda on her question is that sounds like it's a really important question. Yeah. But we are not the people that she needs to be asking that question to. She needs to be asking those questions to the people that are actually involved in our clinical care, whether that's up here, whether that's in the tertiary, the very specialised centre that she's been referred to. They sound very sensible and very valid questions. Yeah. They're not ones that we can give an answer to without wouldn't be appropriate for us not being in that kind of particularly specialised area. But, just hopefully she can get an answer to them, and that whatever moves forward from there works out well for her.
Agreed. So we hope things go well, Rhoda. I think the guys have got some fantastic feedback there for you, but understandably, we can't go into too much in depth there. Moving on to Gail Crampton, a little bit touching on a question that we had earlier on from Joanna Rowley, but we'll touch on it again. Education and future employment is a huge hurdle for our young people. What do they do if they just aren't well enough to do a full-time job? How can they be financially secure or provide for themselves if they have to? Gail, I'm not sure where you're from. So in Scotland, the Catherine McEwan Foundation has a scholarship programme to support our kids of exam age, and hopefully within the next 12 months or so we'll be supporting the gaps in primary school learning as well. So we hope, we know that that's making a difference. It's a service that we're very, very proud of, that's now in its 6th year, that is achieving some, well, we're not, the service isn't achieving it, the kids that are going through it are achieving it. So that's fantastic. On the employment side now, and we know for many that employment's a hurdle, and sadly there are occasions where some people can't work.
Yep. I think it kind of comes back, a lot of that comes back to what we've discussed earlier on, which is, if someone's struggling to work, the first question that us as IBD clinicians, as IBD doctors need to think of as well, are there things that we can do that can turn that on its head? Can we get this person better so that that's not an issue and a concern anymore? And so that should be something that we should be thinking about. And that's something that that's maybe a valid question for the patient themselves or their family members to ask of their clinical team. Beyond that, people should be being supported to work as much as they possibly can, and because you can't discriminate against somebody because they've got a health condition, and so they should be getting supported, and whether that's from an existing employer or whether that's through through government agencies, through benefits and through getting people back into work. That should be something that they should have support with. And again, our role is often to provide some medical background to that, to make sure that it's clear that they should be getting supported, whether it's a letter. Sometimes we need more specific, a request, for example, from benefits agency to give a more detailed response, which will allow people to get supported. But those are things that we do quite commonly for people. I have to say we would always be much happier if we can get that person better and they can get on and they can and that becomes an irrelevance. But it's something that sadly we have to deal with sometimes. Yeah.
Well, I hope that's answered your question, Gail. Jude Curry back in again, stealing the airwaves, but she's got 3 questions this time.
It's a bit greedy, that, isn't it?
You need meter, she's just such a drain. I'm only kidding, Jude. What
that 5-star review's just
I know that if Jude could, she would give this a 6-star review, only because of you guys, but clearly. What privately available medications would you like to see available in the NHS in the future?
I don't think. I mean, in terms of the treatments that we've got for IBD just now, there's not anything that you can get privately that we can't currently prescribe in the NHS. All the licensed treatments that are available, are available through here. There's going to be more treatments coming. Sometimes there's a little bit of a lag with treatments that are maybe licensed in one part of the world before it comes through here. So sometimes in the US and then comes over here, but. There's not generally a situation where people can get things privately that we can't give in the NHS.
I think the NHS and the healthcare system in the UK and in Scotland does get a bit of a battering sometimes. But actually, we do quite a bit of IBD research, and in fact, a number of the drugs that are now licensed, we went through some of the clinical trials with patients in the local area. Digressing slightly, we don't recruit as many people into clinical trials in the UK as we would like to, and part of the reason for that is we have very good access to drugs and equitable access to drugs. So the NHS offers these drugs to everyone. Whereas when you look at other countries within Europe, countries within North America, they recruit a lot more patients into clinical trials, and the reason for that is that access to drugs is much more difficult, or at the very least, it's very much more costly.
Yeah.
So all of the evidence-based drugs that have been licensed for use in Crohn's disease and ulcerative colitis, I think without exception, we can prescribe for our patients. We do have algorithms that give us guidance as to what first-line therapy we should use, and one of the big topics that is a focus of attention for people like myself and John Paul at conferences and stuff is what order should we use drugs in? Should we combine different drugs together? So these are some of the things that are challenging us. But I think we're quite lucky in that certainly if you're talking about drug treatments, pharmacological treatments, I don't think there's really anything that we wouldn't have access to. We sometimes can access what we call off-license drugs, which are drugs that are not licensed in inflammatory bowel disease but are used in other conditions. And again, in certain circumstances, we do use drugs which aren't licensed for inflammatory bowel disease. But again, we are lucky to work in a healthcare environment where, by and large, we can access those drugs and are supported in that process. And I don't know if there was anything in specific in mind that Jude was alluding to that we're maybe not thinking of. But
I feel as if you've loaded it, Jude, and there's something that you maybe.
I suppose the only thing I would add to that is, it does vary across the country, and in Scotland in particular, I think, and in the west of Scotland, I think we do have, we have good access to treatments. I think there are different structures in place in England in terms of drugs that are available to them, and that they must use before they use another drug. Again, a lot of the decision making, and people will often ask about, if this drug, is more expensive, why don't you use that drug if it's a little bit better than that drug? And again, one of the challenges in the NHS is, you've got a rationed healthcare system, you've got a limited amount of money, and what you want to do is to deliver the most benefit for the most number of people. Now, obviously, you take that, when you're in an individual decision making, with a patient, then, there are other factors that you consider as well. But, we all always have to consider that, there is a limited resource there, and we have to use it to the best of our abilities. But we're lucky, I think, in terms of the treatments that we've got available. And people, I think, often look out with the UK and think, the healthcare service is much, much better here or there. But as Jonathan's alluded to, if your access to a lot of these treatments in North America and the US in particular is not necessarily, it's likely to be more challenging to get access to a lot of these drugs than it is here.
I think in a nutshell we've got great, from what you guys are saying, we've got great access. What I would be interested in is, Jude, if there's something behind that question that maybe you've heard of or experienced, we'd be interested to know about, I think.
Absolutely.
Moving on, interesting one. If there was
this is Jude's next question, is it?
I'm very conscious of the time to get through these, actually. Not just Jude's, everybody else's. These are awfully popular, boys. These are awfully popular.
First time for everything.
Exactly. Don't know us. So.
Well, these are awfully popular before the show. If there was no financial limitation, what would you focus on?
Well, that's a very good question. I think if there was no financial limitation, it would allow you to do so much in terms of, the service that you deliver. I think there are things where we've had to focus, or we've had to maybe, move away from in NHS care because we haven't had the resource, the unlimited resources to look at that. And it probably comes to some of the more holistic, the more ancillary aspects of managing somebody. And it's things like, psychological support. And again, the Catherine McEwan Foundation has done, some fantastic work with the mental health support for our IBD patients. And that's something which we have, fairly limited access to, and that's not just a Glasgow or West of Scotland thing, that's across Scotland, we know that. And that's because it comes down a little bit lower on the priority lists versus having access to a surgeon or an IBD nurse or a dietitian. But it's a really important thing, and there's lots of evidence that it's important to the patients, it's important to the outcomes. So if we had unlimited money, I would be investing in some of those wider services. I think. I
would agree with that. So I think certainly, again, there's a lot of good things, and we're actually quite fortunate where we work, and you don't always appreciate that when you go to work on a day-to-day basis, that you're quite fortunate. There are other things that we would like to build into our service.
Working with him every day, you don't appreciate how...
I was going to ask if I can just get that little sound bite just sent to me, just so that I can replay it to him repeatedly.
Yeah.
So if you're talking about the here and now and what would be impactful now with what we know today with unlimited resources, then having everybody with IBD having access to a helpline, having nurse specialists, being able to access a dietitian, being able to access a psychologist, having IBD experts across the UK would be what you would do, I think, to make impact now with unlimited resources. If you're talking about the future, I mean, I think that there are lots of, from all of the angles that we've talked about in terms of holistic care, things using artificial intelligence, things looking at dietary interventions, fatigue, all of these things, this research is ongoing, but research takes time and it takes a lot of money, and therefore if you had unlimited amounts of money, then we could potentially speed up some of this really interesting and exciting research that is going on, but will just take time with the financial constraints that people are working in. If you had unlimited money, you can speed that up. So if Judah's got unlimited money, we're very happy to go back and speak in more detail. She's got
unlimited questions.
Well, Jude's husband John is taking on our 3 peaks in 24 hours challenge.
Okay.
So depending on how much money he raises, then that can help this a little more.
No pressure, John.
The moral of the story there is, John, get your finger out on the old fundraising.
Yeah.
Fine. I think it's finally for Jude on this particular post. How would you educate more people about IBD? Now, I mean, we could go on forever on that, but I think we should, in the interest of getting as many questions in as possible, maybe one thing from each of you guys.
So I think from my point of view, there is a big opportunity for group education within the NHS. And there is a lot of anxiety about patient confidentiality and other things which preclude that. And I think, again, that's where the Catherine McEwan Foundation can potentially come in. But I think we could and perhaps should try and formalise group education, interaction a little bit more within the NHS. I think it happens outside a bit more, because the education piece, sound like a broken record, I think it's really important that the education piece is done, because otherwise it makes the whole management of the condition much more difficult. Yeah,
I think something you touched on. So within the next couple of months, we'll have moved to a new site that will act as a kind of almost like a halfway house kind of thing to the Greater Katie's House project, and we'll use that as a hub, as well as our working office. Yeah. But what our idea was to, in partnering with you guys and other experts in the field, would be that we had these educational things in the timetable. Yeah. So I think it's almost like, we know what, I think as a team, I mean, you guys and us, we know what's a lot of the stuff that's required, but it's actually having the platform and the space to actually do that. Yeah. So that's definitely something that we'd be up for. I
think there's a lot of educational resources out there. There's lots of, you touched earlier on about, the internet being a difficult thing to navigate for a patient sometimes, and it really can be, and it can sometimes give quite a skewed view. There's some really good evidence out on there. The Crohn's Colitis UK website's got a lot of fantastic information on that. But I think there is more that we can do. I think raising the profile of IBD in general will help that. And we've talked about this before. It's about trying to reach people who maybe aren't comfortable, going onto the CC UK website and seeking that out themselves, who maybe, don't on an individual basis seek out that, the educational resources that are available to them, and something like Katie's House, is potentially a great opportunity for that. Absolutely. To give a focal point, but in a slightly different way, so that some of the people who are maybe, can be brought in other ways. And so I think that kind of approach could really be helpful.
Okay. Moving on, Mark Jones has got a couple of questions. Do you think IBD care should be the same across the UK for all young people? I think probably we could adults in that as well, potentially, Mark. It's noticed that some services are better in different areas, although most seem to be failing IBD patients, and should consideration on first diagnosis include support package or leaflets for parents and children? Oh, yeah, well, I mean, I think there's IBD standards, and I think Crohn's and Colitis UK just released a pretty damning report that to say that the care wasn't great.
I think that so there's a couple of bits to that question. Should the care be the same everywhere? I think the there should be the same expectations of the standard of care that you achieve. How that's delivered will vary from place to place, and it has to, because you're dealing with different hospitals, different health boards, different geographical areas and such like. But there are IBD standards, as you said, and that's what people should be aspiring to. And there are deficiencies in what we deliver. I'm sure of that. But there's a lot of people working very hard to try and improve the services that they work in, to improve the care that's delivered. But I think it's always helpful that there is that there is a light shone on areas where we're not meeting those standards. And,
absolutely.
Yourselves do that, CCUK do that. There's been a lot of involvement with the government in certain areas, things like home care services, which haven't been were discussed in Parliament last year. And again, there's the British Society of Gastroenterology, which is our kind of professional society, are heavily involved in lobbying for better IBD care. So yeah, I think you should expect a standard across the piece, whether it's paediatrics or adults, and I think we still need to work hard to get to those standards.
Absolutely.
I don't think there's anyone who's passionate about IBD care up or down the UK that doesn't recognise the challenges and doesn't want to try and address them, and are trying to address them in a number of ways. But it can be difficult.
It's quite complex, and it's not simple.
It is a complex issue, and I think there are some people who are delivering really good, high quality IBD services that don't tick all of the boxes of the IBD standards. But again, there are people who are delivering fantastic care with virtually no resource at all. And so I think that the fact that the services aren't always in place, as you say, are very complex, and it's often not to do with a lack, or I think almost universally, it's not a lack of A, recognition, or B, desire to do better.
Absolutely.
Everyone wants to do better. And so we all need to work together again on that, and try and constructively and helpfully improve services across the country, as I think you've been a great advocate of.
Yeah, absolutely. And I think what people need to understand is, just on one end of the scale, if a service or an experience isn't particularly good at any one given time for any one given reason, the people involved in that, they don't want it to be poor. They're in the role and in the position that they want to help people, and they want to make that experience and the support that they can give as good as possible. But sometimes there's so many pressures and so many things on that particular service that it's almost like, there's sometimes fight with both hands tied behind their backs.
And again, it needs to be a joint effort, because again, sometimes one of the problems that we've had over the years in the NHS is that, that we think we know what's right for the patients, and we just develop a service in a certain way that, this is going to be the best service possible. But actually, we're not the ones that have to live with this condition. We're not the ones that actually are using this service. And a lot of, what needs to be done needs to be, fed back from our patients as well.
And it's not IBD specific, and it's probably not been rolled out in IBD at all. But actually, in Scotland, there's been a lot. Scotland's you've got 2, 3, 4 big population centres, but you've got people who live in the Western Isles, and there's vast areas of the Highlands where healthcare is difficult to access. So there's actually been quite a lot of work, not in IBD, but in other conditions, treating people with strokes, other things, as to how you can try and make sure that somebody who's living 50 miles from a hospital gets the same care as somebody who's living just around the corner from a hospital, and particularly when you've got a condition that requires what you call secondary care or hospital oversight of the condition. Offering a service where we work, we will have a lot of people who are in the city and can easily come and interact with our service in person, but equally we've got people in Campbelltown and in the Isles and other places, and you have to just create modifications or differences in the system if you want them to have the same experience as someone who lives in Partick or Govan or wherever.
Fair enough. And Mark's added in a little bit relating to PIP. Should it be easier for children with IBD to claim? It's hard to make others understand the impact it has on a child. Mark, to be honest with you on that, I think that's a universal thing and a real social challenge that's not just inflammatory bowel disease. Where the challenges come is that, it's a bit of a box ticking exercise, and not every condition, certainly not inflammatory bowel disease, can tick that box. So it's very, very difficult to articulate. So there are challenges. What I will say, Mark, is if you are in Scotland, there's a support service coming very, very shortly from Catherine McEwan Foundation that will support claims.
And there's two elements to that. People obviously are in many circumstances finding it difficult to, we've already talked about keeping full-time work and need assistance with a number of things, but the stress and anxiety around the PIP application process has been and continues to be very difficult, not just in IBD, but so there are challenges across the board with that, which are at government level and at UK level. Again, I think both John Paul and myself can and do offer support that we can. And one of the things and the challenges of inflammatory bowel disease, as JP has alluded to, is people often look superficially from the outside normal. And sometimes you can feel, with IBD, you can feel absolutely indestructible on a Monday, and by Thursday things can have completely changed. And again, the whole PIP process and if there is waxing and waning of symptoms and waxing and waning of need, so support that you might need one week, you maybe don't need another. We don't really have an environment that caters for that. We don't have an award system that, in my opinion, seems to cater for that or take that into account.
It's a real challenge. We need to try and get through these, because I know you guys have got some real work to do at some point.
We do need to get back for clinic, in fairness.
Right, where do we go? There's a few people messaged in that will absolutely kill me if they don't get their questions in. Very passionate. Katrina of famous colitis with Katrina fame from Instagram. Fabulous page, Katrina. Really informative. Now, you've got a number of questions. I don't know if we'll get through them all, but we'll do our best. Can you share a memorable success story that reinforced why you chose this field? Lighten it up a wee bit.
I'm probably struggling to think of one specific, but the things that the things that I would say are the success stories that stick in your mind are the people who you've known for a period of time, and they've come and you've maybe met them at first diagnosis and they've been very unwell, and you've managed to get their disease well controlled, and they've gone into a long-term remission. And the things that probably, mark out that being successful is you've then joined them on that journey, and you've seen them, achieve lots of other things. They've been diagnosed, late in secondary school, and you've managed to get them well. They've got through the exams. They've come through university. You're seeing them. They're they've got their first job. They're about to get married. They're having their first kid. Those type of things. That's the success. It's actually not the treating their disease. It's success. It's about being able to make sure that, I've said this a couple of times, so I'm not a broken record. It's about being able to make sure that they're able to do all the things that are actually really fundamentally important.
No, but you say that, but it's really so important to reinforce that, isn't it?
Yeah,
absolutely.
I would agree with that. So always, we get people that come to us people aren't, when we meet them, by virtue of the nature that they're meeting us, that they're often not in a good place and the illness is not well controlled. And then seeing those people develop the confidence in their health and the confidence in themselves, so that it sometimes creates difficulty for us. Someone will come and say, well, I'm going to go traveling for a year in 6 weeks time, and what we're going to do about my infliximab, or and that can create a little bit of, well, normally the nurses that have the responsibility to sort that out, but that's brilliant. You know, when you're empowering someone to go and do the things that they've wanted to do, or when they go off to university, or when, you know, an old person that's been stuck in the house for 4 months because they've been frightened that they're going to soil themselves, and they come back and they see and they say, I've got a new dog because I'm out walking now every day and I feel I can look after a dog. And actually there's lots of stories like that. And again, we don't, you know, people. We don't
There's
always
a lot more stories like that than people that you can think of where, you know, you think, you know, we've never quite managed to get on top of things, and we're still struggling.
But I think that is important, because again, we've already touched about, you know, the internet, and people go on the internet, and
it's a skewed perspective.
It is a skewed perspective. So to anyone that's out there that is having a really rubbish time and their illness isn't in a good spot just now, it's, I think, harder to find the success stories when you go onto the internet and see that actually the more normal outcome is that the storm settles and the dust clears, and that doesn't unfortunately happen for everybody, but we are, you know, in a much more fortunate position now than we were a generation ago, of being able to get more people into a position where these conditions do not have long-term such a significant impact, but you don't always read about that or see about that.
But
so I think for us to say that actually we can think of not one specific, but lots and lots and lots of examples of that is a really important message to put out there.
Yeah, but I think you touched on something that's kind of that's a societal trend as well. You know, where people go online and talk about the bad things. Yeah. You know, that's quite common. Yeah. You know, there's very few going out there with a big success, and even if you look at, you know, something we've actually spoken about on GUTSY a few times is like, if you take inflammatory bowel disease, what's in the media and what's in the press, it's often the extreme side of it, you know, and that's not for representation.
That's not to criticise people who are online
and
who are giving a representation of their, you know, their disease journey, because that's very important and very valid, and seems clearly important to them, but also to the wider IBD community. But, you know, what I'll often say is that, you know, if you are that patient I've described and everything's gone really well and you've gone through university and you've got your job and you've just had your first kid, you probably don't have the time to be, you know, reflecting back on it and posting about it. And, you know, actually that group of patient isn't necessarily represented. And so you've got to look at it and you've got to take on board what you see, but you've also got to take it in the, you know, in that context.
Brilliant. I totally agree. Right. Katie McKittrick, we'll move on. Katie McKittrick's one of our young ambassadors. She's great. Have you met Katie?
I have met Katie,
She's great. Hello, I'm in second year studying immunology with a dream to work in IBD research. I was inspired by my medical team at the Royal Hospital for Children, who introduced me to the Derek McEwan Foundation, and they helped me get work experience with Bostas. Costas. I find the future of IBD overwhelmingly exciting. What field of research intrigues you most?
That's a good question. I mean,
this girl's going to take over, guys, just so you know.
I mean, I think if you manage to do work experience with Costas and interact with Costas for a few weeks at a time, then you're definitely on a trajectory to good things. If you can deal with Costas.
What are you trying to say here, Jonathan?
Yeah, well, we work quite closely with Costas. He's a one-man machine, and he's a phenomenon, and he's a great advocate for all sort of IBD nutritional research. But he has high standards.
He's walking backwards now, isn't he? So we should answer Katie's question, particularly because me and you need to get a clinic. But the you know, I think it is a really exciting time to be involved in IBD research, and I think there's a lot of stuff going on. I mean, and on the outside, you know, we've talked already about, you know, how many more treatments we've got available and how, you know, how much better a position that we're in than we were, you know, 20 years ago, maybe even 10, 15 years ago. But actually, you know, there is still a massive unmet need in terms of the treatments we've got available. We need to understand a bit more about why IBD occurs, you know, what you know, how we can treat it more effectively, because there is still, you know, a group of patients that we struggle to get things under control.
Yeah.
So, you know, understanding, you know, the immunology, which is what Katie's studying better, and there's been some interesting work that's been done in the last couple of years and was kind of very widely publicised on trying to understand the immunology of IBD a bit better. I think there's a lot that could be done there. One of the things that we've been very interested in, and that she'll have, you know, experienced with Costas, is, you know, the role of diet, you know, because again, that lots of patients ask us that question, and we've got an understanding up to a point about how diet, interacts with the body, and how it influences Crohn's disease. We've got less of an understanding, I would probably say, in terms of ulcerative colitis. But you know, I think it's a really exciting time to be involved in IBD research, and I'm sure Katie will be hopefully a big name in that in years to come.
Indeed.
Remember the name.
So there's a lot. I mean, there's lots and lots. So pre-diagnostics is something which I think is really interesting. So identifying signals in blood or stool that mark somebody out as going to develop inflammatory bowel disease potentially years before you're actually aware of the condition manifesting itself. And we know that if you take Crohn's disease, for example, about 1 in 5, 1 in 6 people already have a complication of the condition by the time they present in front of someone like me or JP for first treatment. So getting to a point where, you know, we can have pre-diagnostic markers and potentially identify an individual who has a very, very high likelihood of developing ulcerative colitis or Crohn's disease in the future.
Wow.
And then, so, I mean, that's not for tomorrow in terms of the months or even, 1 or 2 years ahead, but there is really exciting and interesting work looking at that. And I think it's important, again, that people know that, in certainly maybe not my working lifetime, but within the next 10, 20 years, we get to a position where the management of inflammatory bowel disease is completely unrecognisable from what it is at the minute.
Yeah.
Hopefully.
Yeah, it's certainly going that way, I think. Okay, Anna Reid through Facebook. What is the best management options for fistulating perineal Crohn's disease who have failed infliximab?
That's a difficult one.
Yeah, they could get that. That could be quite a detailed and complex answer to that question. But it's not necessarily a massively uncommon scenario. So people who've got perianal fistulas, tracts between the bowel and the skin on the tail end, mark someone out as having disease that is potentially more tricky to treat and does need more treatment. Infliximab is the first line therapy that we use in that situation, in that scenario. I think there's a number of treatment options that you could consider after that. It would depend on a number of factors, like how effective infliximab actually was. Why is it thought that the infliximab has stopped working? What does most up-to-date imaging at the tail end and of the fistulas suggest? And I think, without wishing to dodge the answer, I think you need to. So, I think, again, if you went back 15 years, we didn't have many treatment options. There are other drug options that can be considered now with relatively new drugs, and they're still building up their evidence base of use in perianal disease, but are showing good promise.
I think the kind of background to that question, I think, what Anna's getting at is most of us recognise that anti-TNF medications, and perhaps infliximab in particular, are likely to be the best drugs for that. We talk about a phenotype, which basically just means a pattern of disease. So having perianal fistulating Crohn's, which can be really, really difficult to treat, it's quite specific, I would say, in how we manage it. Is that it often needs a really good kind of collaborative approach between us managing the medical side and the surgeons being involved, because often, there's a need for surgical interventions to help. Like lots of areas, there is a lot of interest in trying to develop new, more effective treatments. And some of those treatments are drug treatments. Some of them are other interventions for the fistulas themselves, so surgical treatments. It's a really difficult area to study because, one of the things with IBD is, IBD is not actually that common, although we talk a lot about it.
Totally.
And
because you're in that world,
and
you think it's
and
everywhere.
then within IBD, having Crohn's disease is only a subset,
and
then having perianal fistulizing Crohn's disease is a smaller subset. So actually, the evidence to support what works and what doesn't work is more difficult to generate when you get down to a much smaller subset. But as Jonathan says, some of the newer agents that have come through, there's some hope that they will show similar efficacy, so effectiveness in patients with perianal Crohn's. But they probably don't have overwhelming evidence to say that once you failed an anti-TNF, this is going to be your next best bet.
Yeah.
So it's a discussion, it's a reassessment of the disease. Are there surgical options? Is there anything else that we can do? And, if you look, there will be all the other drugs that we have available that are used in licensing Crohn's. There will be some evidence that they may be effective, but perhaps, there's more to come in that regard, and hopefully there will be.
Okay, I hope that helps you out there, Anna. Anna, I know you've got another couple of questions, but we need to get another couple of people in before these guys get to their clinic, because they do have real work. Two more,
Yeah.
you think? Yeah. This is actually from Katie Kittrick's mum.
Yeah.
Oh, no. Hi, Christina. My daughter, 19, has Crohn's and suffers from a little bit of food anxiety. Despite her best efforts to eat the rainbow, some days she struggles, so I feel she'd benefit from a multivitamin or supplement of some sort. Are some multivitamins more easily absorbed than others? What would you recommend? And I think the first thing is what Christina thinks is correct.
So I think probably most of the people that we see who have, so you're at risk of nutritional deficiencies if you've got small bowel Crohn's disease, because your small bowel is where you absorb nutrition. Once your disease is well controlled, then that should be a fairly unlikely thing for you to suffer from. There are specific things that people can often be deficient in with small bowel Crohn's. So if you've had the last bit of your small bowel, your terminal ileum removed, or if it's inflamed, you won't absorb necessarily vitamin B12. So often people are injections for that. But most of the other things, if they eat a well-balanced and healthy diet, they will be. And most of the nutritional deficiencies we probably see are because people aren't actually just getting the right balance in their diet. So if that's, so the first thing, generally, just speaking in those circumstances, is they may benefit from some input from dietetics. And if it's clear that maybe they are struggling to have all the nutrients that they need, then there are multivitamins out there. You can usually buy these, over the counter, and I'm not sure that there's any evidence that one's any better than the other. But if your small bowel's healthy, you should be able to absorb it regardless of what it is. Yeah,
most of these vitamins are absorbed in locations of the small bowel that are unlikely. Most vitamins, vitamin B12, a couple of others are the exceptions, but most of them are located higher up in the small bowel, which can be involved in Crohn's disease, but it's less likely.
Much less likely.
So there are some other things. Some of the medicines that people are on actually impact upon the absorption of other vitamins. So I think, or kind of impact upon the absorption of vitamins. I think, as JP has said, I don't think there's any evidence that one nutritional supplement is any better than another. So if you are in a position to be fortunate enough to afford to take a multivitamin supplement, and you have inflammatory bowel disease, and in particularly if you're having to modify your diet significantly because of symptoms that you get from certain food groups, then I think that taking a multivitamin, my personal opinion would be that taking a multivitamin is a reasonable thing to do. But I think you can go in and buy a generic brand from the supermarket. I don't think you need to buy a really specific one. The further point beyond that is anyone that has inflammatory bowel disease that's coming to clinic, or even if they're not, should, in an ideal world, particularly if you've got Crohn's disease affecting your small bowel on an annual basis, you should have your vitamin B12, folic acid levels checked, your vitamin D levels. So there are things that we, in the medical service, should be checking on an annual basis, and if there are specific deficiencies of measurable vitamins related to some of the things that we've discussed, then they would often separately get replaced, and sometimes have to get replaced, vitamin B12 in particular, in injection form sometimes, if you really can't absorb them because the lower part of your small bowel has either been removed or is inflamed or scarred.
Okay, one for the road.
Yep.
Sounds good.
This is from Rona Harvey. Thank you, Rona. How closely connected are your gut and brain? Can emotional factors, stress, cause IBD or make it worse?
The short answer to that is yes, absolutely.
So, I mean, your gut and your brain are. Yeah. I mean, I think most people can probably recognise how closely they're related. And you know, the analogy that I give to my patients is you only ever have to have, ever had to go to a job interview or sit an exam, or be nervous about the questions that Derek's going to ask on his podcast, and you feel, your tummy's churning and you're having to rush to the toilet. He just had to go before we came in, but
he actually did.
He did
too much,
and that's because there are a lot of the kind of chemicals that are released in the nervous system have an impact on your gut. So there's a close association there. And so it has a bearing undoubtedly on, gut symptoms. And we know that from other disease areas like irritable bowel syndrome, which is very, very much akin to that. Whether it actually triggers IBD is a little less...
Yeah, it's complicated, isn't it?
Clear.
So, I mean, if you take a step away from IBD, as JP has just sort of alluded to here, people will be familiar with terms like IBS, or irritable bowel syndrome, dyspepsia, which is, again, a sort of syndrome of bloating and pain after eating. These have recently been sort of redescribed or reclassified as disorders of gut-brain interaction. So that fundamentally, the answer to the question is there is a huge and not always fully understood link between your emotions and other stressors and what happens in your gut. Whether that is exacerbated in people who also have inflammatory bowel disease, whether it's linked to the inflammatory process itself or whether there is something that becomes, secondary responsiveness or behavioural following someone having been diagnosed with IBD is a little bit more difficult to disentangle. But I think that we know that stress, emotional stressors, other things have a very fundamental impact and can have a very profound impact, particularly on some people with inflammatory bowel disease, by no means all. But there are also a subset of the population that come to see people like me and JP in clinic who categorically don't have inflammatory bowel disease, that have very, very severe symptoms of pain, bloating, discomfort, rushing to go to the toilet, which is going back to the very beginning, why sometimes establishing a diagnosis of inflammatory bowel disease can sometimes be difficult, because actually those types of symptoms are quite common even in people who don't have ulcerative colitis or Crohn's disease.
I think there's an important point, which is, I think the jury's probably still out a little bit as to whether or not stress can actually trigger a flare of IBD and, an inflammatory flare, so to speak. But what is undoubtedly the case is that you can have more than one condition overlapping at the same time. So quite a lot of people, so I mentioned a minute ago that inflammatory bowel disease, although we're talking about it, and we got lots of patients that we know with IBD because that's what we do, it's not actually that common. Now, other gut conditions and gut symptoms generally are much, much more common. So irritable bowel syndrome is, you've maybe got 20% of the population, probably more, who've got irritable bowel syndrome. So there's often an overlap. And sometimes stress will give you gut symptoms in the context of IBD, but it's not your IBD that's actually driving those. Yeah, and you need to be, I think, open to that, both as a patient and also as a clinician, because if you pick the wrong diagnosis and you try and treat it, you probably get the wrong outcome.
I think that's all right. Absolutely right. I absolutely agree with every word about that. It goes back to this team sport again about inflammatory bowel disease, because there aren't really good drugs to treat either the triggers for those stress or sometimes the irritable bowel syndrome type symptoms that can be superimposed upon inflammatory bowel disease. There aren't necessarily good drugs to deal with that. I think that's where particularly psychologists come in. They have a big role on a number of levels, but one of the things that trained psychologists can do is offer some support in terms of helping coping strategies for when, to manage stress, to try and avoid getting to that tipping point where psychological stress tips over either into a flare or into to disordered gut-brain interaction symptoms, because that can be a quick downward spiral if you're not careful, but it can be very difficult to disentangle. And I'm not an expert in that, and I don't think JP would claim to be either. So again, we do need other people, particularly psychologists and others, that can help support people with this type of problem, and expertise, which we as clinicians would like to have more knowledge and expertise about, but one, we don't, and we probably don't have the time or the skills necessarily to develop the tools to help people in that type of area as much as we would like to.
Yeah, I mean, just thinking back, I mean, obviously I was relatively young, but I think stress and worry was always a thing that I remember my mum.
Yeah. Naturally,
was something that absolutely, I related that to her being quite ill when she was stressed. So, I think for a lot of guys,
a bit of a chicken and egg though, there, isn't it? When you're feeling physically poor, you're less able to deal with the mental side of stuff, and vice versa.
Yeah, totally.
So it's a really complicated area, which comes to what Jonathan's saying, which is having good support, psychological support for patients, would be a real benefit.
Well, guys, I think it's fair to say I'm really sorry to the people that we've not got to with their questions, because there's so many more. Some of them are, most of them are, all of them, and have their merits, and
it's a pity we didn't get through them all.
They're really interesting.
So does that mean we have to come back again?
If we get to 1,000 5-star ratings, we'll come back again. Is that what you're saying?
So we won't be back. Sorry, that's fine. You can clear the diary.
It's fair to say we could have spoke all day. Thanks to everybody who's asked the question. I sincerely hope, and I'm sure that you have got something from that. We would love to have you guys back, because again we could definitely have spoke all day, but I kind of thank you enough for coming on, GUTSY.
Thanks for asking us.
Dr. Jonathan MacDonald and Dr. John Paul Seenan, thank you very much.
Thanks,
well done,
Derek.
guys.
Thanks
thank you
for the questions. Bye.